Today, let's talk seizures. First off, what is a seizure? A seizure is just abnormal extra electrical activity in the brain, and that manifests itself outwardly in some form or fashion. So it depends on where in the brain that extra electrical activity is and how much extra electrical activity there is. So many causes of seizures, anywhere from medical conditions or external triggers. You can have a history of epilepsy, be prone to seizures. You can have one seizure and that's the only time in your life you'll ever have a seizure. So when you have a seizure patient, we also have a lot of digging to do to find the underlying cause of it. And not only are there many causes to seizures, but there are many different types of seizures. So a seizure isn't that classic full body shaking, unresponsive patient. There are many types. Could be a focal seizure, could be generalized. Just depends on where that electrical impulse is, and again, how powerful that electrical activity is. We'll start by talking about our focal seizures, our focal onset seizures. So it usually begins in one hemisphere, and we categorize it whether or not the patient is aware, or if there's some sort of impaired awareness. So yes, you can have a seizure in which you are fully aware that you are having a seizure. So these would be your focal onset seizures, where your symptoms are that of awareness. Is your patient aware? Then we have our generalized onset seizures. Instead of one hemisphere of the brain, this is now impairing both hemispheres, affecting both hemispheres of the brain. And we further categorize this into motor and non-motor. And as motor and non-motor, pretty self-explanatory. Your motor onset seizures, are going to manifest in muscle activity. You'll see the twitching, you'll see maybe stiffening of body parts, right? You'll see it outwardly manifested with muscle activity. Non-motor seizures, you're going to have sensory changes. Might be changes in smell, taste, hearing, any other senses. You won't see that muscle activity, but the patient will report some sensory changes. And this also might include auras, which we'll get into a little bit later on, but maybe visual auras will be present as well. For your motor seizures, I've got four main types of motor seizures, from absence to atonic. We've got myoclonic seizures, and then our classic tonic-clonic, that full seizure, which we are typically called out for. These are your motor seizures. Of all these seizures, we do have examples for you, video examples for you in another presentation. But these are the types of motor seizures that you'll be encountering. And for our seizures, for these generalized seizures, there are different phases, different stages. First might be an aura. Some seizure patients have an aura, some don't. This is some sort of sensory warning sign. Might be visual, might be olfactory. Is some sort of sensory warning sign that something is about to happen. So if they say they're experiencing an aura, be ready to react to whatever follows. Then we've got a loss of consciousness, and then we go into this body rigidity. It's our tonus, and then we go into our muscular jerking, which is the clonus. So we get our tonic-clonic seizures, and then finally, when it subsides on its own, we have that postictal state, wherein patient stays responsive or unresponsive, and then once they regain some responsiveness, they're confused a little bit, and then that confusion gradually improves, and they become alert, oriented, and back to normal responsiveness. And instead of generalized seizures, your patient may be having a partial seizure. We've got simple partial and we've got complex partial seizures. With simple partial seizures, there's no loss of consciousness. There may be localized tonic-clonic activity, and this may progress to Todd's paralysis. And Todd's paralysis is a state after the seizure activity in which there is one-sided weakness, may imitate a stroke. You may see some one-sided facial drooping But it does, TOS paralysis does come back on its own, does resolve on its own after a little bit. Complex partial seizures, look for repetitive motions. You've got that repetitive lip smacking, repetitive swallowing. The patient does not have a memory of this, is not aware of complex partial seizures. Simple partial seizures, the patient is aware of it is aware of what's going on. There are also Jacksonian seizures, which start. This is a progressive seizure. It starts locally, starts focally. Maybe their finger starts twitching. The patient is probably going to be aware of this or know what's going on. They are going to be alert oriented when it starts, but they're going to be aware of what this means, and they'll usually look to you and say, this is how my seizure starts. So Jacksonian seizures start small, let's say with that finger tremor, and then it will progress and progress and progress up until a full tonic-clonic seizure. So with Jacksonian seizures, if they say this is how it starts, you start seeing some, let's say, we'll go back to that finger tremor. Be ready to treat a full body tonic-clonic seizure. Then we get into status epilepticus, defined as 2 or more seizures without regaining consciousness in between, and or continuous seizures for more than 5 minutes. This is serious. Mortality rate is upwards of 10%. For these patients, because it can cause respiratory failure. There's significant neurologic damage leading to death, and requires us to be fast and to be aggressive with our treatment. And then lastly, under our types of seizures are pseudo-seizures, which are actually very common. It is not, quote-unquote, the patient just faking it for maybe for attention. They are very common, a number of different reasons why your patient might have a pseudo-seizure, but they are capable of activity during the seizure. You can do some reflex tests that we've talked about before. There's different signs, Babinski, Hoffman sign, things like that. Look at the eyes and how the eyes are reacting. Are they squinting? Their eyelids, what are their eyelids doing? So many different causes of pseudo-seizures. They are common, and don't pass it off as the patient just faking it for attention. There could be an underlying cause. So let's get into our assessment and treatment of our seizure patients. First and foremost, our assessment is largely determined by the patient's seizure state. Are they currently having a full-body seizure? Are they conscious? Are they unconscious? Are they aware? Are they unaware? Are they impaired in any way, shape, or form? Are they in a postictal state? So what is the patient's seizure state? Are there bystanders around? Are there family around that can give you information? So that's where we're starting our assessment. And our history taking is very important. Do they have history of seizures? If they do, what's the frequency? When's the last time they had a seizure? What medications are they on? Are they compliant with those medications? Have any medications been changed recently? When's the last time they saw their neurologist? Are they taking any supplements, or have they had any drugs, any alcohol that typically don't mix well with seizure medication? So have they had anything that may change their serum levels of their seizure medications? Also, if someone can describe the seizure activity, how long it's lasted, was there an aura? Can we ask the patient, is the patient aware, was there an aura? What type of seizure was it? What signs do we see? Do we see any tongue biting? Did the patient have a seizure, come out of it? Bystanders or family telling you, how long it took. So timelines are important. Again, we're looking for any traumas, any head traumas, any recent history of fevers, headache, neck stiffness, looking for signs of infection, and then any other comorbidities, looking for heart diseases, diabetes, even stroke history. And for your focus seizure assessment, along with that history taking, we're getting back to those cranial nerves and evaluating our cranial nerves, particularly paying attention to those pupils. And then we're assessing our motor and sensory function, looking for coordination, and that's going to be dependent on what seizure state your patient is in, and as they progress. As they get better, maybe they're coming out of a postictal state. We're doing this assessment multiple times. As always, we are evaluating vital signs, making sure they're not hypoxic. We are always checking blood sugars on these patients. Hypoglycemia can cause seizure activity, so we are checking for hypoglycemia, checking blood sugars, and always putting them on the monitor, looking for any cardiac arrhythmias that can cause seizures as well. Now, you might be called out for a seizure patient in which they are just, I shouldn't say just, but they are a syncope patient. So what's the difference between syncope and seizure? There is, in syncopal patients, bystander family, whoever's there might see some muscle jerking, some of those kind of myoclonic jerks. It might think it's a seizure, call you out for a seizure. So it's important for you to differentiate whether this was a syncopal episode or a true seizure, because our treatment and our assessment going forward for the two is going to be a little bit different. As we start our treatment for a seizure patient, every single seizure patient, we're going to expose and look for possible causes, look for possible trauma. So anything we can see on or around the patient. Every seizure patient is going to get an IV, and get that IV when you can. Just in case they have another seizure, we're able to give IV medications to them. Every single seizure patient is going to get their blood sugar checked, and every single seizure patient is at the very least going to be put on that 4-lead, but definitely get a 12-lead as well. Now, because we got that IV, we might want to give some seizure medications. It's important to know what our seizure medications, how they work, what are the mechanisms. And there are 3 primary ways that our seizure medications are going to work. Either they are inhibiting influx of sodium or calcium into the cells. There's also GABA stimulation, so we can stimulate GABA, slow down a seizure and that electrical activity. Or another neurotransmitter, glutamate, we can inhibit glutamate. So our medications can do one of these things, or they can be a combination of a couple or all of them. For paramedics, typical protocols have benzodiazepines as their first line, typically Versed or Ativan or Valium. So Versed, 2 to 5 milligrams. Give that IV, you can give that IN or IM. Ativan IV, you can also give Ativan IM. Valium, 5 to 10 milligrams IV. Valium, you can also give rectally if needed. So Valium can be our rectal option if needed. Most EMS agencies have gone to Versed as their frontline benzodiazepine for seizures, but you have multiple at your disposal. For your OB patient, your pregnant patient, or even postpartum, they could be a month, a few weeks postpartum, we're still going to treat them. Their body's still in kind of pregnancy mode. So for OB seizures, we can reach for magnesium, giving a larger dose of magnesium than we would for cardiac patients. So 4 grams of mag sulfate for our OB patients. And then if we need to control the airway, RSI is available to us, but it is a last resort. And remember that when you give that paralytic, the seizure activity will stop, but it's not stopping the actual seizure. We're just stopping the muscle movement part of it. The electrical activity and the neurologic damage happening in the brain is still occurring. So we still need to treat the seizure itself, even though we have stopped the muscle movements with our paralytic. Using a sample seizure protocol here for you, we do see midazolam, Versed there, as a front line frontline treatment for the seizure patient, but also maybe throwing in Dilantin. So phenytoin, your agency might have that available to you, 20 mics per kg over about 10 minutes or so, or it could be infused. If you've got an IV pump, again, if your agency has it, Dilantin, phenytoin is also within our scope of practice. It's something that you might see. We will not be using it as paramedics, but you might see your patient having this device, a vagus nerve stimulator. So it does exactly that. It stimulates the vagus nerve and creates these electrical impulses that cause release of GABA and glycine within the system, so this endogenous GABA and glycine to try to control that seizure activity. So there will be a device implanted, usually in the left chest, running up to the vagus nerve, and the patient controls it with a magnet. So that magnet there, placed on the neck, stimulates the vagus nerve, stimulates release GABA and glycine, and hopefully controls the seizure activity when your patient recognizes the beginning of some seizure activity. And then at home, your patient might be prescribed some seizure medications that they'll take every day. You might see these in the hospital. Things like Tegretol or phenobarbital. We've already talked about Dilantin, phenytoin. Might see Depakote. So that Dilantin, which again is within our scope of practice, inhibits that sodium and calcium influx. Phenobarbital goes after GABA. Depakote does both GABA and inhibits sodium and calcium. Might see gabapentin, or called Neurontin. That's a GABA analog, so stimulates GABA receptors. And then there's an older drug, Lamictal, which inhibits glutamate and blocks sodium channels. There is a pretty gnarly side effect to it. Some patients suffer from Stevens-Johnson syndrome, which can become pretty severe, sometimes life-threatening. So you see Lamictal prescribed less and less nowadays, but these are some common medications you'll see your patient on at home. As always, if you have any questions, please let us know.